Again, this is a schematic. This is a representation of a publication where they used a metal plate to reinforce the fusion. I use local bone from the pelvis. The pelvis has a hard shelf of bone. I use small pieces of that to reinforce it for the wire around. When you get the fusion between the ribs and the scapula, some sort of supplementation here is a demonstration of metal plate. But all this would be representative of the bone graft pieces you pack in from the pelvis to really try to get this to become a large mass of bone so that it's solid and does not move. This is what it looks like on a couple different patients I've done. So again, here would be an individual where I had basically fused 4 levels together. This one 4 levels with, this was actually at one point in time, this was back in 2007, I've used the bone stimulator. I don't think I've used one from about that time. On the other side, we went ahead with just a 3-level fusion. Sometimes you decide 3 versus 4 in the exact position based on where the scapula best fits against the chest wall. But we typically try to line up the really stout portion of the scapula here. It's called the scapular spine. This is the best bone in the scapula right here. We usually try to line up this, what's called the scapular spine, to either the 3rd or 4th rib backers. So there's thoracic ribs, the 1 through 12. We usually try to line up the spines to either the 3rd or the 4th thoracic rib. So I'll take an X-ray in the OR to make sure the position is appropriate. If you put this spine too low, the scapula will sit too inclined and the arm will be way up. If it's too low, it'll limit. Too high, it'll limit how much movement you can achieve overhead. So there is some critical decisions there in the OR between where to put it. Procedure, now I can do this procedure start to finish in about 2 hours and 45 minutes or so. You get some bleeding. It's a relatively big exposure. I mean, a typical blood loss now with some of the things we do control blood loss is about a unit, maybe 2. Very rare. I don't think I've ever transfused but 1 person in the 20-odd years of doing this. So pretty rare to need that. Hospital stay has gotten shorter because we're more aggressive with our pain management. It's gotten shorter because, unfortunately, as you all might know, here healthcare right now is very difficult getting paid for these days. So they're not. Sometimes we're really bartering and on the phone with the insurance companies trying to get a 3 or 4 or 5 day stay approved. But we do what it takes to take care of the patient. They make it difficult sometimes. Routine to get 24 hours of IV antibiotics to prophylax infection. Pain management is where we spend a lot of our efforts here. This is a procedure that can generate moderate discomfort. We're not stingy with narcotics and use them appropriately. The operated arm, once we're done, will go to protective sling immediately from the OR, and then I'll talk about how we proceed from there. The complications you worry about are obviously the generic infections. The generic issues we always can see: anesthesia complications, infection. I've never had one in this procedure. I've never had neurologic complications in this procedure. Mostly there are issues in the field. It's quite possible that you could puncture the lung while you're passing the wires and get an air leak. It's called a pneumothorax. A significant one would require a chest tube. I've never had a pneumothorax. I've been doing these for 20-some years. I'm very careful how we do it. I have had a fair amount of bleeding around the ribs in a couple individuals. That actually what will happen is there's obviously bleeding in the cervical site, but if you get enough of it, it'll push the lung away from the chest wall and get a pretty good collection. We call it a hemothorax. A significant enough collection can cause you to feel short of breath. And I've had 2 occasions in 20-plus years where we've actually had the patient under ultrasound by the radiologist have to have that drained because we thought it was really contributing to their post-op breathing sensation. It's very common for patients, especially when they have the first side done, to really come out of surgery feeling like they're aware of the fact that we've operated back there. They're splinting a bit. They'll describe a sense that they might feel a little, not quite short of breath, but it's difficulty. That usually goes away as the comfort improves, but it's you'll see that post-op. It's really more of an expected symptom than anything. Here's what it is that we talk a lot to patients about what you need to be prepared for in the event of the procedure. So for the first 6 weeks, we really want to keep that fusion site quiet. The wires are very strong, but they're not strong enough to tolerate the stress of everyday movement. It's like bending a paper clip. You can bend it several times, but you bend enough and pretty soon it breaks. So, and the purpose of the wires is to hold the scapula to the ribs until you've got bone-to-bone healing. And that process takes time. If you do too aggressive movement too early, there's going to be some micro motion there. It's hard, and it can break the wire, so you can fail the fusion. We'll come back to that. So we're very meticulous early on to put your arm in a sling 6 weeks. You can't use the arm for anything spontaneous during the day. Well, nowadays I let people probably type on an iPad or a phone or a computer, but you can't use it for lifting, reaching, dressing, any typical daily life activities. We will, however, have you get into the hands of a very good therapist. I want to have the patient do range of motion of the wrist or elbow, even some very controlled movement of the shoulder joint, what we call passive motion, so the shoulder joint is actually moving. If you completely immobilize this and don't let the ball and socket joint move, it will get stiff post-op. So we're very restricted about active movement, but we'll have the therapist do passive motion, show the patients how to do that. That could be dangling activities called pendulums very carefully, some activities in the pool where the arm kind of wants to float in water a little bit, and obviously a lot of this under a therapist. So I'm very meticulous. If we have a patient leaving the area, I try to talk to the therapist in very detailed instructions on what I want them to do and what I want them specifically not to do. By 7 weeks, we usually have some early bone healing. So now we can start the stress diffusion side a little bit. Allow individuals to wean themselves from the sling when they're comfortable. They can start to do more aggressive passive motion, really get the arm fully up overhead with assistance. Try to do active movement where you're trying to lift it, water pull, some light day-to-day activities around your house or your job. Not a whole lot of muscle strengthening to wake things up, if you will. But you can get back to most activities of daily living at this time with some careful precautions. By weeks 12 to 20, this is when we really expected that fusion is going to be solid. And what we want to really see by 4 to 5 months is the patients come in, they got very good active movement, they're getting back to day-to-day functions, not letting you lift anything unrestricted, so the landscaper doesn't get released to the landscaping duties at 20 weeks, but 12 to 20 weeks, but really trying to promote more aggressive day-to-day activities. By week 5 months on, this thing should be solid, and it will let you. We expect a solid fusion. You watch on the X-ray. How can you tell if it's not fused? Number one, it hurts. So when the fusion side heals, it doesn't hurt, right? And then also on X-ray, you won't see any sign there's any movement there. There's anytime wire breaks, sure there's movement. So if it doesn't fuse, it'll be painful, and you'll see wires breaking. So if we get to 20 months or 20 weeks out and they're fine, I'll let individuals do pretty much whatever they want to do. And then you can have an individual in therapy. If they feel like the shoulder's a little stiff still, we'll basically have continued therapy under the guise of a good therapist. Results, typical patients will notice dramatic improvement of their overhead function and day-to-day activities by 6 months. But they're going to continue to get better as they adapt to this and the muscles come back to full function up to a year afterwards. The typical elevation you'll achieve is about 145. What I mean by that is a lot of FSH patients will kind of struggle to get to here or maybe even perpendicular. We really want you to get easily about this position. So get your hand up in the shelves. You're not going to get, most individuals can go 170, 175. Most times you don't get that. You really need full shoulder, full scapular movement to achieve that. But 145 is perfect for what we consider functional shoulder arc of motion, and that usually is very acceptable for most individuals. Again, the goal is resolution of the winging, elimination of the scapular discomfort from that, but the fundamental goal of this procedure is really to improve the shoulder range of motion and day-to-day functioning. Problems you can see, I've had 2 non-unions in patients that I've done this on so far in my career. One was a smoker. Smoking is the #1 risk factor for bone not healing. It's controllable risk. It's one of the most controlled risk factors. So if you happen to be a smoker, I'll tell patients I won't do this procedure unless you stop smoking. It's just not. It's too much of a risk to go through the operation, have it not heal. The revision is too grave, too hard of a problem. The other one was really non-compliant with post-op restrictions. Unfortunately, it was a gentleman from Michigan, and we did one side, it did fine, and we did the other side, and due to circumstance, he went back to his job as a chef too early and broke down his fusion, and it didn't heal. I never do bilateral procedures. Dr. Thompson, who I mentioned earlier, had done 1 or 2 individuals that were bilateral, and both of them had a non-union on the one side. It's just really hard to take both arms away from anybody. So by human nature, you're going to cheat on one side. You just have to. So I don't ever do bilateral procedures or simultaneous procedures. The stiff shoulder, I've been able to avoid that more recently. I used to put people in the sling for 6 weeks, not do anything with them. Once you get a stiff shoulder, it's really painful. The stiff joint, the ball and socket between hurts. So I'm more aggressive with controlled therapy, and I really had been able to avoid that over the last decade without much of a problem. Painful wires, we're very careful in the OR to try to bend the twisted portion of the wires down out of the way. I've had to remove the wires once or twice. It's pretty rare, but it's not a major ordeal to take the wires out. You can make the incision again, just pull, you cut and pull the wires, and there's no period of restriction back after that. But it's always nice to avoid having to have any additional surgery. So the need to go back for wire removal is pretty rare. In terms of durability, people always ask, well, how, if I'm better now, is my result going to be durable? As all you in this room would know, FSH is not, unfortunately, a stagnant process. And I knew of individuals who have very durable function over long times. Other folks, if they do go on to develop any involvement of the disease process with the cuff or the delta, you can lose function later. But usually the result's very durable, and people are quite satisfied for extended periods with that. And there's the ring.